Hello, everyone. So my name is Dr. Ampadu. I am a heart failure cardiologist at Prisma Health, University of South Carolina, and we are going to discuss ATTR amyloidosis treatments. So before we talk about treatments, we want to identify the specific type of ATTR amyloidosis. So the first categories we want to put our patients in are ATTR cardiomyopathy, so that's ATTR-CM, and then we have ATTR polyneuropathy, ATTR-PN. And then we need to categorize patients into having the wild-type version and the hereditary version. So if you see in this table here, this lists the specific drug therapies that are indicated for that particular type of disease. So for wild-type ATTR cardiomyopathy, we have stabilizers, and we also have one silencer, which is an RNA interference therapeutic. And similarly, for hereditary ATTR cardiomyopathy, we have a stabilizer and we have an RNA interference therapeutic. For hereditary ATTR-PN, we have silencers, which are RNA interference therapeutics, and then antisense oligonucleotides, so ASOs. So first, our stabilizers, we have tafamidis, trade name Vyndamax and Vyndaqel. So as we have a tetramer here, the tetramer can dissociate into monomers, as we've seen in more information from ARC, but the stabilizers will bind to the tetramer to prevent its dissociation. So that's how tafamidis works, and the route is oral and the frequency is daily. And in trial, in the data on tafamidis, we see improvement in survival, reduction in cardiovascular hospitalizations. We see patient-reported outcomes are improved, and then we see improvement in 6-minute walk distance. Moving on to our next stabilizer is acoramidis. Trade name is Attruby, and same mechanism of action. So we have stable tetramer. The issue is if it dissociates into monomers, leading to amyloid fibrils, stabilizers bind to the tetramer to prevent its dissociation. So the route is oral, and the frequency is twice a day. And the data shows improvement in survival, cardiovascular hospitalizations. We see an improvement in 6-minute walk distance. And then lastly, we see an improvement in one of the blood markers, which is a natriuretic peptide, that when it's elevated, it can represent wall stress and wall stretch. And we see an improvement in that as well. So this is indicated for ATTR-CM. Moving on to our silencers. So RNA interference therapeutics first. We have vutrisiran, trade name is Amvuttra. So the way that this works, you have a double-stranded small interfering RNA. So it targets the specific messenger RNA for TTR, which encodes the transthyretin protein, and then it degrades it, or it leads to its degradation. So the route is subcutaneous injection, and this is administered by a healthcare professional, and this is once every 3 months. This is indicated for ATTR-PN because the data shows an improvement in polyneuropathy testing. And then recently, we have a new indication for ATTR-CM, and that showed improvement in survival, cardiovascular events, which included hospitalizations and urgent care visits. And then we see an improvement in patient-reported outcomes and 6-minute walk distance. So our next RNA interference therapeutic is patisiran. Trade name is Ampadu, and similarly, it's a small interfering RNA. It targets TTR messenger RNA that encodes for the transthyretin protein, and it leads to its degradation. So the route is intravenous, and this also has to be administered by a healthcare professional. This is once every 3 weeks. Its indication is for ATTR-PN, and we see in the data improvement in polyneuropathy scores. And our last is antisense oligonucleotides. These are ASOs. We have eplontersen, trade name is Wainua, And this mechanism action, you have ASOs that bind to hepatocytes. They target TTR messenger RNA that encodes for transthyretin protein, and then it leads to its degradation. So the route is subcutaneous injection. This can be administered by a patient or by a healthcare provider. And the frequency is once every 3 months, once every month. And this is indicated for hATTR PN, and the data shows an improvement in polyneuropathy scores. So when we treat ATTR, again, we have cardiomyopathy and polyneuropathy, but we have many different therapeutics for this disease state, therapeutics that work on the suppression of transthyretin, therapeutics that work on the stabilization of transthyretin, and then we even have some therapeutics that we use for disruption. But depending on your disease state, your provider may be able to see which is best for you. So if you have any further information, we recommend that you go to an amyloid specialist so they can find the best therapeutics that are needed. So thank you all for joining. If you have any further questions, please get more information from ARC.